I'm actually going to talk again later on today, but first talk is basically to explain who we are and what we do here at University of Colorado. All right. I am a medical oncologist. I focus on gastrointestinal cancers, hence I'm here. But I'm also trained under Dr. Eckhart, who you've met, and I'm also in development therapeutics, which is a fancy word of saying I'm a drug developer. So, I am actually one of the few people in our department that actually remember the old campus. I know Dr. Anand actually remembers it.
I was born there.
But University of Colorado Hospital was actually located at 9th in Colorado, which I would say about 2 months ago was demolished, finally, and actually created some space. But due to a number of reasons, and particularly that we were not able to expand, we had an opportunity to move to the Fitzsimmons Army Base, which was actually vacant at that time. The rumor is we bought it for $1. Construction began in 1999. The Cancer Center was the first building to be built. We moved here about 2002 or 2003. And the research building, I believe, was about 2004 and 5. And actually, the hospital opened, but only opened one floor at a time. The first people to come out here were one of the first. So we had this big, huge hospital. We had one floor, but I had to commute back and forth. 2009, 2010, the entire hospital basically transferred out here. This campus right now is about a mile by a mile. It's about halfway done. There's a golf course in the back, which actually will be going shortly. It will be now be converted into a biotech park. Next door, you already know, is Children's Hospital, and they moved a few years after the hospital moved. And fortunately or unfortunately, in the news about the VA hospital being, I think, $1 billion over budget, is actually on campus as well, and it's on the eastern side of the campus. The Cancer Center is unique because it's not just a single building; it is actually a consortium. It is made up of several universities, several hospitals, and a couple of institutions. The obvious one is the biggest collaboration is between University of Colorado Denver, which is actually who I actually officially work for. University Hospital, Children's Hospital next door, a county hospital, Denver Health, which is across town. Our mother campus, as you could say, is UC Boulder. We actually work with CSU, which is great, what makes CSU extremely great is they actually have a cancer center for animals, and it's the largest animal cancer center in the country. Combining with our patients, it is actually, Colorado is actually the highest accrual of people on clinical trials, men and animals, I guess to say, in the entire country. All right. We also have collaborations with the VA Medical Center, where Dennis Anand is. National Jewish, up to this point, that may change in the future. And then as well as we have Kaiser across town, who actually provides a lot of database. I've also named the appropriate heads of all of them. Now, we are an NCI designated comprehensive cancer consortium because we're just bigger than one center. There's only a few, but they actually just mainly classify as a comprehensive cancer center. And I'm actually giving you the definitions. If you just mainly see patients but provide enough services, then you'd just be qualified as a designated cancer center. However, if you go beyond that and just do laboratory work, you're an NCI laboratory cancer center. And if you do both research as well as provide clinical, then you're obviously a comprehensive cancer center. So you may often hear people say, "Oh, we're a comprehensive cancer center." I'm not exactly sure what they mean, but if you ask most cancer centers, it's usually the NCI designation of actually having to do research as well as clinical care. And you must have certain number of specialties. And that does the spectrum from all the way from prevention to all the way to what I do is regarding the treatment. Now there are actually about 40-ish comprehensive cancer centers, and I've sort of circled where we are at the University of Colorado, and we have a very unique geographic opportunity. And the main reason is we're the only comprehensive cancer center, not in Colorado, but not even the few states that are, we're one of the two, if you include University of Arizona, as being the only ones in the Rocky Mountain states. So we have a huge referral base. I have patients from Montana, Wyoming, obviously Colorado, West Kansas, because we're only 3 hours from the border, but it could be another 7-8 hours to Kansas City. We do have people from New Mexico, Utah, so we have a huge catchment area. Now our vision is that in 2025 we'll have the lowest cancer mortality rates in the nation, and we're going to achieve this by doing personalized medicine. It is a very common, thrown out term that everybody uses, and hopefully during the next 2 days you'll learn exactly what we mean by personalized medicine. Our mission is to discover, develop, and deliver, and we do this by hitting the 3 big areas of that is basic research, clinical research, and also include prevention, clinical care, and as well as survivorship. All right. So far, so good. With the NCI, we have achieved a lot of fundings, $97 million in directs and $122 million total in cancer-related funding that we got in 2013. And here's a rough summary. I just want to focus on a couple of things. We do about 1,000 different clinical trials. And not only do we do a lot, we actually put a lot. We put about 22% of our patients go on a therapeutic clinical trial. I was going to ask you this later, but I'm going to ask you now. Okay? So when the question comes up later, you should all get it right. How many people actually know the average of people going on a clinical cancer trial in the United States?
A couple percent. Even.
Yeah. Yes?
10% or 1%? It's like really low. One is 2%.
It's 2 or 3%. That's it. Okay. All right. Now the cancer center, because we go across a couple of hospitals and campuses and all that, we have 258 members as part of this cancer center. Now, since we moved here, we have been steadily growing. And actually, we've averaged about 5 to 10% growth per year in terms of new patients, number of visits, and even the faculty. I think when Gail became division head, how many? Like 30?
Who's half the size you have?
Yes, she hired 30 new faculty in just in the division of medical oncology, and that's not including all our surgical counterparts, people doing basic science research and all that. All right, so where are we right now? We're estimated to see about close to just under 10,000 adult patients, with that accumulates to about 69,000 visits. And 19% of these will be actually enrolled in clinical studies. Okay, slightly better than their 2%. All right. Also recently, there's been a formation of what we call UC Health. So not only is the hospital, not only the cancer center itself is expanding, the actual hospital network is expanding. We have now recently joined with several hospitals, which is down the I-25 corridor, which is where close to 80–90% of all the entire people in Colorado live. So we actually have a consortium of hospitals and obviously patients that we actually are now responsible for. Right? The whole idea is to actually allow everybody access to the care they can get here. So they'll come and maybe get their opinion here, but they can actually get treated closer to home. All right. In the last few minutes, I'm going to talk about some of the research projects that we are doing here that actually helps with this personalized medicine. One is actually we are now being part of the Orion project. Anybody notice something unique about this or incorrect? As a ploy to get me to drink a little more coffee.
It's not spelled like the constellation.
Exactly. So they used the Orion constellation, but Orion's constellation has an O in it, so they spelled it with an E. All right, but they tried to make it fit. So what is this? So this is a project that was initially started by Moffitt and Ohio State. They got, I believe, at least $150 million to set this up. And basically, it is taking genetic information of people's tumors, and then we're trying to correlate how they're going to do. So instead of just sequencing someone's tumors, I'm going to back up a little bit. 2004 was probably one of the biggest advances in medicine, or actually in science in general, is the sequencing of someone's DNA. Okay? Our DNA is made up of what we call base pairs. There's 3 billion of them, which represents about 30 to 40,000 genes. All right? It took 14 years and a cost of $4 billion to sequence that one person. We don't know who that person is. Rumor is it could have been Watterson or Crick, actually, the person who actually discovered the DNA. That's the rumor. So it took us 14 years. Fast forward 10, 11 years now, we can now sequence someone's entire DNA in about 6-7 weeks for a cost just under $20,000. It is anticipated that in the next few years, we will get down to several weeks, and hopefully it will be under $1,000. So now you have all this information, but we also have to realize, what do they mean? So we will need to understand, did it put you higher risk for something? Because having it doesn't mean you're going to get something. So that is actually a joint effort to collaborate tissue specimen, the data, and actually clinical data. The rumor is we're going to collect 50,000 data points per patient. So we're going to know like what they get in the future, what type of cancers, how they responded to drugs, and then try to correlate that, which is actually excellent. Because right now, every single place is doing it, but that information is kept at that site and not shared among others. And if everybody's doing it, it'd be nice if you could actually share the data. All right, number 2, in the back there, John Tedler wrote a very pivotal study based off some of the research we have here. For decades, we have been doing research on what we call cancer cell lines. So what is that exactly? We took cell lines that are able to grow in a dish by itself without a body, and we've been testing all this time. Well, we're now realizing, especially with the DNA sequencing, they no longer represent the true cancers of a human that they were derived decades ago. Okay? Yes, we called it pancreatic cancer, but it doesn't behave like a real pancreatic cancer patient. So the problem is, if our models aren't very good, how are we going to predict what drugs are going to work or not work if they're not accurate? All right? So how are we trying to improve on this? We're here at University of Colorado do what we call patient-derived xenograft models. Okay? You guys remember the Avatar movie? This is like Avatar of a person's tumor. So what does that mean? People who are going to surgery and consent that we are able to use their tumors, when it's removed from surgery, gets transplanted into a mouse. That mouse will grow that person's tumor, and hopefully over the next year or two, we will have many mice with that person's tumor, and that we can actually start testing. The mutation of that person's tumor, of that real person, resembles that of the patient. So hopefully, if we have enough, and enough drugs to test, we hopefully can do clinical testing on patients' tumors that are actually sitting in mice. Okay. And we think that is a much better model than actually looking on cancer cell lines that can grow without blood or without a body. All right. Also, our University of Colorado started the Center for Bioinformatics and Personalized Medicine. It is a joint between the Division of Medical Oncology, And we are now starting to collect mutations, okay? You see on a lot of television, people will say they'll get their insurance companies to pay for these mutations and all that, but it really doesn't tell us a lot of information, okay? Because we don't know what it means. The difference is we will collect this information for research purposes to understand what these mutations mean. And we will talk later on today, my afternoon talk, what mutations and how that can help us. All right? But this is a multi-million-dollar effort to actually expand, not just for cancer, but for all other diseases, Alzheimer's, and where genetics can also be important for that as well. All right? For example, this is our panel. In colorectal cancer, there is only one FDA-approved mutation. It's called KRAS. Okay. We also do a little BRAF here because even though it's not FDA approved, we think it's very informative in terms of how we should treat a patient. The Europeans also add NRAS. We have done that here as well. But there are, depending on the NCI match, which we'll talk later on today, or Foundation of Medicine, they do 300 to 400 mutations. So there's a lot more mutations that we're discovering, but we're trying to understand what they mean. And we're actually collecting our own panel of cancer tests, which will be aided into the Orion project as well. Okay. So why do we do research here? As I said before, well, one more thing I did include is University of Colorado is also part of the NCCN network. It's called the National Comprehensive Cancer Network. It is about 42, 43 institutions across the country, and its job is to come up with guidelines on how do we manage to go through the data, how do we manage patients with certain cancers, i.e. colon cancer, all right? How often should they be screening? They basically come up with guidelines that every oncologist in this country follows. It is the same guidelines that insurance used to follow to see whether or not they pay for something. So if the drug is not FDA approved, but the NCCN recommends it, the insurance company will actually consider paying for it. Sometimes we sit on this board, and sometimes I don't even agree with my own board. All right.
Strike that from the comments.
And we have a UM1 grant. What is that? That is a big institutional grant that actually, there's only 10 in the country given. We have ours with MD Anderson, and that is the drug development to take new stuff and to do early clinical trials with. Okay. I've said before, because of our location, we are the not only the only comprehensive cancer center nearby, we're actually the major player nearby. There is no university medical center for hundreds of miles, right? So I trained in Philadelphia. In Philadelphia, there's about five or six big cancer centers, plus we have several big universities. But then you drive another hour south and you're in the Baltimore, drive 2 more hours south and you're in DC, you drive an hour north and you've got New York. So there's in such a small radius in terms of 4 or 5 hour drive, there are literally tons of universities with their own medical center and they're all competing with each other. We actually don't have that competition. We actually, our closest competitor, MD Anderson, is actually most of the time are our collaborators. Like I said earlier, we have the largest animal cancer center with CSU. Because we're the only player, we are the big tertiary center. So we're not only tertiary center for cancer, we're the tertiary center for the hospital, which means you get sick in Montana, Wyoming, you're flying here. The VA, which is being built, is actually the tertiary center for the VA of the next several states, and Children's tertiary center for the next several states as well. So 3 hospitals side by side are the tertiary center for not this state, but for the several states.
Do animals get colorectal cancer in the wild?
Yeah, they do.
Do they?
It's not real common, but they definitely do.
Is it similar genetically to?
I don't know that. I'm not sure about that. They tend to, dogs getting colorectal cancer.
That animals with
I
colorectal.
know they get it, but I don't know whether
Incidence.
it's
I don't think it's as common.
50% KRAS mutant or wild type.
Uh,
I mean, they definitely get a lot of sarcomas, and they've looked at human sarcoma and dog sarcoma, and there's a lot of similarities.
Yeah. Thanks.
I'm gonna fast forward to the last point since my time is up.
You're a minute over.
Boy, one more.
No, you're right on, you're right on.
Right on.
It's 9:44, go!
Go.
So, I also want to tell you, we also have a very big stem cell program and a very big immunotherapies. In the news of late, it's all about your immune system fighting cancers. You see tons of commercials for the non-small cell lung cancers. We actually have a very big immunotherapy program that we're actually building upon. Also, we have a very big stem cell program. Because the other concept or the other theory is that think of cancer as like a beehive. You can kill off all the drones, but you're not killing off the beehive. But if you can find that 1 or 2 stem cells, i.e. the queen bee, hopefully you can wipe out the whole hive. All right? So there's that concept in very cancers like pancreatic and even colon, where we think there's a stem cell that is responsible for all of them. Okay. All right. That's it for me.
Thanks, Steve.
That's awesome.
All right.
I know from my own experience that there was a lot of vocabulary there where people were going, And so write down your vocab questions if you have them, and I'm happy we'll all go through them later. It takes a while to get the lingo. You'll learn it. You will learn it.
Very great. And so while we're having you, thank you so much.
Yep.
And we, as I mentioned before, we captured one fun fact about everyone who's presenting, all of our medical team today. So Dr. Leong's fun fact is
Oh, I'll change it right now.
Let's hear it.
I was DC, sorry, so I'm bipolar. So yeah, I've been to the North and South Pole.
What was the one you gave me before?
That was that one, I've been to the North and South
The
Pole.
Arctic and Antarctica bipolar. Well, thank you.